Hi, everybody. My name is Dr. Lauren Murphy. I'm a doctor at Boston IVF and one of the reproductive endocrinologists. And I wanted to talk to you today about miscarriage and recurrent pregnancy loss, especially because this month is Pregnancy and Infant Loss Awareness Month. And so we're trying to bring a little bit more education to the topic and a little bit of a better understanding surrounding what is loss and why is it occurring. So we're going to talk a little bit about that today. In terms of how common is pregnancy loss, very common. Upwards of 1 in 4 pregnancies will be lost, and this may sound like a shocking number, but really a lot of these pregnancies aren't ever sort of acknowledged or documented because the losses happen so early. Loss is considered a loss anytime you have a pregnancy that was and then wasn't, okay? So a lot of my patients will ask me about a biochemical pregnancy. Is that considered pregnancy loss? And I think if we're talking about loss, of course, biochemical pregnancy is considered a loss. You feel it, and we as your doctor acknowledge it as well as a loss. It's thought about a little bit differently depending on how far along that loss is, just in terms of clinically what it means. But I'm going to go through some of those definitions today, and we're going to talk through it. So one way to define a pregnancy loss is, as I had mentioned, a biochemical loss. A biochemical pregnancy loss is one where the pregnancy implants, but then is rather quickly basically loses its implantation and the HCG level declines. So this might be a scenario in which you take a home pregnancy test and it's positive one day, and then maybe 2 days later you get your period and you check again and the pregnancy test is negative. That would be considered a biochemical pregnancy loss. In the world of fertility treatment, this might be where you had the blood test to see if you were pregnant and your hormone level went up to 100 or 200 or 300, but then it declines down below that, okay? These are all consistent with biochemical pregnancy losses. Clinical losses are ones where we actually see something in the uterus that then stops continuing, or you end up passing on your own. This is what's called a clinical loss or a clinical miscarriage. Now, the typical timeframes for these are 6+ weeks along for a clinical pregnancy loss, and typically less than 6 weeks is when we would consider something a biochemical pregnancy loss. These are just general terms, and really they don't matter that much, especially from a patient perspective. I think each loss can be considered or felt equally significantly, but certainly the ones that are farther along have a little bit of a different meaning from a clinical perspective than perhaps a patient perspective. When you have loss, of course, the first question that comes to mind for most of my patients I know is, did I do something wrong? And the overwhelming answer is no. This has nothing to do with something that you did or something about how you were handling yourself during the time of that early pregnancy. This almost always has something to do with the embryo itself, the vast majority of the time. And I say that because the leading cause of miscarriage is a chromosomal abnormality in the embryo that implanted. And we use a term called aneuploidy. That's sort of the medical term that we often use to describe this, but really we're just talking about chromosomal abnormalities within an embryo. The occurrence of chromosomal abnormalities is extremely common, and the reason why sometimes it shows up for some more than others more frequently is because there are some women that have a tendency to readily implant pregnancies, whereas some other women are perhaps not as readily implanting abnormal embryos. So if there's an abnormal embryo, the most common outcome for that embryo when it drops into the uterus is that it will not implant. So that will just end in a month of a negative pregnancy test, or a regular timed period. Sometimes, again, implants, in which case you can get the biochemical loss or the clinical loss. And sometimes you get a pregnancy that continues on until you get to that prenatal visit at 10 to 12 weeks, and only then do you find that there is an issue chromosomally with the pregnancy. So those tend to be the scenarios for chromosomal loss. Certainly there are scenarios even with later detection of that chromosomal abnormality that can occur farther along at, say, like 18 to 22 weeks, when you might be doing an anatomy scan. And of course, I think the longer that a woman is pregnant, oftentimes the harder that loss is to face later. And so these can be very, very difficult. In terms of chromosomal abnormalities occurring, they can occur for any woman regardless of age. And that means for women in their 20s all the way to women in their 40s. They occur more frequently in women, typically the older a woman is when trying to conceive. And that is really because the reason for chromosomal abnormalities to occur is typically due to a problem with the egg itself. For women, we're born with all the eggs we're ever going to have. And as these eggs sit in the ovaries, over time, the longer they sit there waiting to be ovulated, the more potential they have to have something go wrong with them, which is why as we get older and older, there is a higher and higher percentage of abnormal eggs that could potentially lead to abnormal embryos, in future pregnancies. So in your early 30s, we would expect roughly 70-75% of eggs to lead to chromosomally normal embryos, because those eggs, the quality of those eggs is thought to be very good. As we get to 40, it's more like 50-50. So 50% of the eggs are going to be abnormal, and 50% would be likely to lead to abnormal embryos. And as we get beyond age 50, the abnormality levels really grow significantly, such that by the time you're 44, the vast majority of eggs are going to lead to abnormal embryos, and that's in the greater than 90% range. Okay, so chromosomal abnormalities can happen to any woman at any age, and certainly are the leading cause of miscarriage. But what are some other causes? There certainly are other causes of miscarriage and loss, and those causes are many, and typically we delve into evaluating for those causes if you've had multiple losses in a row. Now, there are different thresholds to trigger the workup that I'm going to talk about, and different pieces of this workup. So this would be something that you'd want to talk about with your doctor when and if to investigate the variety of tests I'm going to mention. But typically, if there have been 2 or more clinical losses, so again, that's that phrase meaning, a loss where you saw something in the uterus grow and develop and then it stopped developing, okay? Those are the losses that we consider clinical losses. And when you've had 2 or more of those, it typically opens up the door for a bigger evaluation into what's called recurrent pregnancy loss. In a setting of multiple biochemical pregnancy losses, those are those losses that happen before anything is seen with an ultrasound. There are some tests that might be offered, after 2 or 3 of those losses, and others that we might wait on. And so again, you can talk to your doctor about this. But generally speaking, the evaluation for recurrent pregnancy loss involves testing multiple systems to see what's going on. One thing that we for sure do is check the thyroid hormone. Thyroid hormone is important in early pregnancy development, and we want that thyroid hormone to be generally in a normal range. If that thyroid hormone is really, really high, and it's significantly abnormal, there is a potential that this could contribute to a miscarriage. Okay. Other things that we test are typically sugars and glucose status, or signs of insulin resistance and frank diabetes. Now, these parameters have to be also usually very significantly abnormal, sort of in a diabetic range, for this to affect pregnancy loss. But certainly for many of our patients who have diabetes, it's important to keep close tabs on blood sugars, hemoglobin A1C, because that can be a contributing factor in if a pregnancy goes on and continues on in a healthful way. Structural issues in the uterus can contribute to pregnancy loss. So we want to make sure that we've evaluated the uterus, that the uterine cavity looks normal, that there's no things obstructing or interfering with pregnancy growth and development, like a significantly large fibroid in the uterine cavity, a septum, multiple polyps potentially. Those kinds of things may have some effect on the potential for a pregnancy to continue on, and even for a pregnancy to implant. Other things that we want to be aware of are fallopian tubes and whether or not there's fluid backed up in those tubes. If there is fluid in the fallopian tubes, that can sometimes, if you have one tube that's closed, for example, with fluid in it, that fluid can come back into the uterine cavity and potentially disrupt, a pregnancy that has attempted to establish itself, because that fluid can be kind of toxic to an implanting pregnancy. So those are some structural things that we'd be looking at. Other interesting blood tests that we may be running is a karyotype. So a karyotype is a way to evaluate a patient's chromosomes themselves and a patient's partner's chromosomes as well. The reason that this becomes important is because it is possible to have some small chromosomal abnormalities within ourselves that weren't enough to create potential problems for a normal functioning human, but when you go to rearrange those chromosomes, it makes it more likely that there are problems with that chromosomal rearrangement when embryos are formed. So for sure, we'd want to evaluate karyotypes for patient and potential partner, or patient and sperm donor, if that were the case. Other things to consider is something called antiphospholipid syndrome. Now, this is a series of tests a series of blood tests that are evaluated to see if there might be factors related to creating blood clots or like microclots that could be negatively affecting an implanted pregnancy. Now, this is not something that we typically do in all scenarios of pregnancy loss. There are very specific indications for when to typically call on this test to see if there's something wrong. Those scenarios often include, frequent loss at 8 weeks or greater, or a single advanced pregnancy loss for no known cause. A loss that happens after 10 to 12 weeks that appeared normal in every way, and we have no reason for that loss. That would be a reason to do this antiphospholipid testing, or there's a couple of a variety of other scenarios, but it's very specific when we want to do this testing. This testing involves testing a bunch of antibodies, again, to see if there's a higher likelihood of developing these, what I call microclots, that can disrupt implanted pregnancy. You can only do this testing if your pregnancy hormone is 0. If something comes back positive, ideally we want to do the testing again to confirm that positivity remains at a distance from the initial test. Now, that doesn't always occur in this world of reproductive endocrinology and infertility, mostly because patients want to get on with having babies. So oftentimes we will, if we find that there are abnormalities in that testing, we will do some kind of empiric treatment, and this can involve things like aspirin or Lovenox as potential treatment options. that really does bring me to what are treatment options for loss. And again, if there's something as specific as antiphospholipid syndrome identified, then this would involve typically anticoagulation with a medication called Lovenox that you would probably do as well in conjunction with aspirin, a low-dose aspirin, 81 milligrams. The frequency of that coming up is, again, very infrequent, okay? I don't commonly see this. I'm not often treating with Lovenox and aspirin, but in some cases it's necessary, and in some cases it makes all the difference for recurrent pregnancy loss, okay? In other cases, I mentioned a whole lot of things that we would be testing to see if they were wrong as, are they contributing to pregnancy loss? Thyroid, glucose levels, structural abnormalities in the uterus. If those things are found to be wrong, then our treatment is correction of those things. So if the thyroid is elevated, it's bringing it down potentially with, levothyroxine and, treatment of hypothyroid. If we find that sugars are elevated, then tighter glucose control, potentially treating for insulin resistance or frank diabetes with insulin itself may improve pregnancy outcomes. If we find structural things wrong, then we're going to want to do surgical correction of those things. Remove the septum, remove the fibroid, remove the polyp, remove the tube if the tube is blocked and has fluid that is refluxing into the uterus. And if we think that the most common reason is this chromosomal abnormality or aneuploidy, then our treatment option potentially is IVF with genetic testing of embryos to try to ensure that any embryo that enters the uterus is a chromosomally normal embryo. Outside of that, we don't have a whole lot of treatment for pregnancy loss. And there are some patients in which we do all the things and they're still having loss. That's really, really hard. That is really, really, really hard for a patient to, I think, manage and cope with. Even a single loss is hard to deal with. And when you have it happening again and again, this can just be so devastating and I think really emotionally draining. It can put a strain on your relationship with your partner. It can really drive a wedge between friends that don't have this problem and are having babies and friends that, and yourself who maybe is struggling with this. And so, the first thing I want to say is I want to acknowledge that this, in some ways, I think this is one of the hardest and most difficult problems to face as a patient going through fertility treatment. But I also think that we have some hope. In addition to the things that I've mentioned and some treatments that we have, there is also a data to suggest if you can continue, if you can persevere, if you are able to get up after a devastating loss and try again, that, many patients, not all, unfortunately, but many patients will be successful with subsequent attempts at pregnancy. And we just have to kind of give you the support to hang in there. And we often see that this can occur, in pregnancy number 4 or even 5, or even 6. But it's hard to do. That's really hard to do. Sometimes in these scenarios of recurrent loss, we will talk about the potential for gestational surrogacy as a way to work around a uterus that just won't keep a pregnancy. And that is, of course, a last resort. And we only go there if we feel very much like we've exhausted all options. So I think, the overall recurrent loss, again, the majority of patients will be facing losses due to chromosomal abnormalities, and our best treatment option there is IVF with pre-implantation genetic testing to make sure that we're putting back a normal embryo. For patients in other categories of loss, a lot of what we do is trial and error. So we're going to do our best to be super thorough with evaluating you and not leave any stone unturned. But then a lot of what we're going to do is going to be trial and error of trying different things and seeing if different protocols, different combinations, different potential empiric medications work. If you are facing recurrent loss, you've probably looked into some other things that are out there about loss. For example, prednisone treatment or antihistamines or, even things like platelet-rich plasma injections into the uterus. There are lots of really poorly studied or not studied potential interventions that you and your doctor may decide to explore if you tried all the other conventional things. But what I would just say is that we really want to try anytime that we can to stick with what is evidence-based and what we have studies to support doing, because some of these other interventions, while we may reach to them if we've tried everything else, some of them are costly, some of them have side effects, some of them may have negative consequences. They're not just a benign opportunity to try something to see if it works. So I would just give you a little bit of caution there, because I do know that when you're in these situations facing loss, it feels very desperate sometimes. So I would just ask you to work with your doctor to try to find the best path forward for you based on your plan in that scenario. But I think, in general, pregnancy loss is common, miscarriage is common, and, we are here to help you with that. We are here to support you with that. The best thing that you can do for yourself, I think, if you're facing loss, is to make sure that you have go-to support system, a partner who's supportive, friends, family who are supportive. We have a wellness center that offers a variety of options, including social work, clinical psychologists, acupuncture for self-support, anything that you can do to give yourself a little extra boost. And a lot of times, really, I primarily am going to recommend seeking out additional therapy or, a clinical provider who can help offer extra support, because this is hard. And I don't want you to feel like you can't ask for help, because you should, and you'll do better if you do. So anyways, I hope that you found this helpful today, and please reach out to your doctor, schedule an appointment if you haven't already for recurrent loss, so that we can hopefully help you to avoid a miscarriage the next time.